Assalamu alaikum, and it's me, Dr. Muhammad Naseem Shirzad. And today, one of the most important topic of urology, and that is varicocele. We will be discussing varicocele in very detail from basic anatomy up to the treatment. So before jumping to start varicocele in a detail, let me discuss the surgical anatomy of the varicocele. The tympaniform plexus, which is actually a network of approximately 10 veins that draining the testes and epididymis, and these plexus surrounding the testicular artery in the spermatic cord, and it lies anterior to the ductus deferens. So these tympaniform plexus above it continue as an internal spermatic vein. We also call it testicular vein. We also call it gonadal vein. So we by various names like gonadal vein, like internal spermatic vein, like tympaniform plexus, like internal spermatic vein. So for us, when we are discussing in our whole discussion, these all will be carry same meaning. Now this internal spermatic vein or gonadal vein or testicular vein, on right side it is draining into the directly into the inferior vena cava, but on left side it first drain into the uh, left renal vein and then into the IVC. So this is the uh, drainage of the testy. On right side it is directly draining into the IVC, and this drainage and this entry into the IVC and renal vein is also important for our discussion ahead, so it's important. So after this discussion of surgical anatomy, now it's very easy for us to understand the definition of varicocele. Varicocele is abnormal dilatation or tortuosity of the internal spermatic vein or tympaniform plexus that drain the testes. When this dilatation is greater than 2 to 3 mm, we call it varicocele. Now let's discuss the incidence of varicocele and the various statistics regarding varicocele. 90% of the varicocele occurring on left side, and only in 10% it occur on the right side. The second important thing is that the incidence of varicocele in general population is 15%, but those presenting to the clinic with infertility, that is 20 to 40%. Now let's discuss the physical examination of the varicocele patient. The physical examination of the varicocele patient is divided into a grading system which is called the Hodgson graded system, and this Hodgson graded system is actually on the basis of the physical examination, and it consists of grade 0. Grade 0 means that the varicocele is subclinical. It means it cannot be detected during physical examination, and it is only identified on ultrasound. So grade 0 means subclinical, cannot be detected in your routine examination, can only be seen on ultrasound. Then the grade 1 is detected only with Valsalva maneuver. What does it mean? It means that you can detect this only when the patient perform Valsalva maneuver, but you cannot detect it on physical examination without Valsalva maneuver. The grade 2 is easily detected even without Valsalva maneuver on physical palpation, and the grade 3 is detected visually at a distance of more than 2 centimeter. You can visually see the varicocele like a bag of worms. It is also important to understand to perform the examination first on standing, and if you found that there is a varicocele, then perform the examination on the supine position in order to see that is it reducible or not. If it is not reducible, it means that there is some pathology like retroperitoneal mass or retroperitoneal fibrosis, which is called Hormonal disease. So in order to exclude this, better to perform first on standing and then on supine position in order to exclude the obstructive causes. Means when it is not reducing, it means there is some retroperitoneal pathology. That's why it's not reducing. Now let's discuss that why varicocele formation occur and why it is more common on the left side. The reason that why it is more on left side include that the left testicular vein, as we have already discussed, unlike the right one, join the left renal vein instead of IVC. So this is one of the reason that it is more common on the left side, that it draining into at right angle to the renal vein instead into the IVC. So this is one reason. Because of this right angle entry into the renal vein, it's common on left side. The second cause that why it is on left side is the nutcracker effect or nutcracker syndrome. Actually, in this syndrome or this effect, the left renal vein, which is passed between the abdominal aorta and the superior mesenteric artery en route to the inferior vena cava, and this is upon compressed by the enlarged superior mesenteric artery. This condition is called nutcracker effect. So this is one of the reason. The third reason why it is on left side is the lack of effective anti-reflex valves at the junction of the left renal vein and left testicular vein. And the fourth reason why it is on left side is the large length of the left testicular vein as compared to the right vein. And what are the causes if it is present on right side? The right-sided varicocele, as we have mentioned, that it is present only in 10%, and it is present much of the time bilaterally, and seldomly it occur isolated. When it is present isolated, must suspect that it may be patient having retroperitoneal mass or some enlarged lymph nodes, or the patient having renal cell carcinoma, and must perform ultrasound in a patient if you found solitary right-sided varicocele. Must go for ultrasound QB. It's important. There is another important question, that what is the pathophysiology of testicular dysfunction, or we can say why the infertility occur in a patient of varicocele. The mechanism by which these varicocele exerts its effect on the testicle remain unclear, but there are several theories that saying that it causing infertility. One of these theory is the loss of heat concurrent exchange mechanism, which is normally occurring. This is lost in patient of varicocele, and this increase in testicular temperature leading into DNA damage and DNA of the sperm and decreasing the spermatogenesis. The other reason behind this infertility is the increase in intratesticular pressure. This intratesticular pressure, which is rising the pressure in the vein, this pressure can also influence the testicular blood flow to the testy, and this again leading into the hypoxic condition and leading into the attenuation of the blood flow, and this again leading into the decrease in or impairment of spermatogenesis. The third mechanism is the hypoxia, which occurs due to attenuation of the blood flow, as we have mentioned, that because of this increase in intratesticular pressure leading into the hypoxic condition. And the fourth mechanism is the reflux of toxic metabolite from the adrenal gland, like catecholamines from the adrenal gland. These catecholamines can cause chronic vasoconstriction and there's subsequent dysfunction in the spermatic epithelium. So one of the reason that is the left testicular vein is coming from the renal vein. So because of the reflux of the toxic metabolite like the catecholamine, and we know catecholamine can cause chronic vasoconstriction, and this leading again into the dysfunction of the spermatic epithelium. So these are the reason that leading to the infertility in patient of varicocele. Now it is also important to discuss the hormonal profile and the semen analysis in a patient of varicocele. The hormonal profile abnormality in a patient of varicocele include, as we know that there is the impairment of the testicular perfusion, and this leading into the impairment of the Sertoli cell function. And you know, when there is a Sertoli cell dysfunction, this leading to decrease in the inhibin secretion, and this again leading into increase in FSH concentration, means the spermatogenesis is actually decreased, and this decrease into the inhibin and leading to increase in FSH concentration. The other is the dysfunction, or we can say the impairment of the Leydig cell, and the Leydig cell function, when it is decreased, this leading to the increase in LH concentration and also normal to subnormal testosterone in patient with varicocele, and this abnormal hormonal concentration are often corrected with surgical treatment. While as much of the patient presented to the clinic with semen analysis in their hand, and much of the time it's showing Wood syndrome. Wood syndrome means oligospermia, means the low sperm count. The A means asthenospermia, means the movement of the sperm or the motility problem, and the other is the teratospermia, means the abnormal sperm shape. But in 90%, the sperm analysis are having poor sperm movement, which is called asthenospermia. And we also much of the time advising to the patient ultrasound, testicular ultrasound, and that to see the dilatation of the pampaniform plexus when it is more than 2 to 3, which is a cutoff value 2 to 3 mm. When it is more than 2 to 3 mm, we label it as a varicocele. So as we discussed that the mortality is decreased first in 90%, followed by the decrease in the sperm count, and followed by the morphology decrease at the last. So first decrease in mortality, followed by decrease in sperm count, followed by morphology, and this is a combination of Wood syndrome. And what are the changes that occurring in the testy itself? That may be gross changes or histological changes. The gross changes which occur in the testy is the high grade varicocele leading to atrophy of the testy, and histological changes include the germ cell maturation arrest and sludging, the tubular thickening, and the interstitial fibrosis. Now the important things that what are the clinical feature of the varicocele, we have already discussed some important point, but usually these patients are asymptomatic, and much of the time these patients present to the clinic around 20 to 40% with infertility, and the palpable mass in the spermatic cord increasing with rising with the Valsalva maneuver. The patient present with a scrotal pain, especially when the patient is standing, and maybe the decrease in the size of the testy called the testicular atrophy, and the primary varicocele is almost variably on the left side, and the patient if present with right side must work up for the patient of retroperitoneal tumor or mass. Now as we have discussed all the detail, now coming to the indication of varicocele surgery or varicocelectomy. So the indication for varicocele surgery include the varicocele that is associated with small testy, means varicocele plus ipsilateral testicular hypoplasia. So this is one of the indication for surgery. The other is the additional testicular condition that is affecting the fertility when the varicocele is bilateral, or when there is a pathological changes in the sperm quality, and the other important is when the patient is symptomatic, and large varicocele that causing physical or psychological discomfort. So if we summarize it, varicocele associated with small testes or hypoplasia, bilateral palpable varicocele, symptomatic varicocele, varicocele that causing changes in the semen analysis, large varicocele that causing psychological or physical discomfort. So these are the indication for varicocele surgery. And what we can expect from this surgical options, it causes pain relief in around 50% of patient. It improves sperm quality in 30 to 50% of patient, and did improve overall semen analysis in 60 to 80%. It increased the pregnancy rate by 20 to 60%. Now let's discuss the various surgical option for the treatment of varicocele, means the varicocelectomy. So there are multiple options including the sclerotherapy. We will discuss it in a detail about the sclerotherapy. The other is the now let's discuss various surgical options for varicocele surgery or varicocelectomy. It includes sclerotherapy. We will discuss it, how it is performed. Then we will discuss transvenous embolization of the varicocele. Then we will discuss the open abdominal, or we call it retroperitoneal Palomo approach. Then we will discuss the open inguinal varicocelectomy, which is also called I1 Wish technique. And then we will discuss subinguinal or inguinal microsurgical varicocelectomy. The open inguinal approach is called I1 Wish, and the open suprainguinal approach is called Palomo approach, and the subinguinal microsurgical technique is also called Marmor or Goldstein technique. Now coming to the sclerotherapy and transvenous embolization of varicocele. For both of these techniques, we can go either integrate or retrograde by embolization of the gonadal vein or internal spermatic or testicular vein. We can use either internal jugular vein, either external or internal jugular vein, or we can use the femoral vein. So we can go through retrograde technique, means through femoral, or integrate through external jugular vein. So we can use these, and how to follow and what to inject, let's discuss them in detail. In sclerotherapy, we cause the venous occlusion by inserting the 3% sodium tetradecyl sulfate or polydaucoconal, or without intravascularization of or balloon, etc. While in case of embolization, we are passing actually a metal coil or loops from the internal jugular vein and or femoral vein. Now let's discuss the pathway for of the jugular vein. Like external or internal jugular vein, we are reaching into the right or left subclavian vein, and from right or left subclavian vein we are entering into the right atrium. From right atrium we are entering into the right ventricle. From right ventricle we are entering into the IVC, and then we know that on left side we will enter into the renal vein and then into the gonadal vein, while on left or right side we will enter directly into the gonadal vein. For femoral vein, we will enter first into the femoral vein. From femoral vein we will enter into the external iliac vein. From external iliac vein we will enter into the common iliac vein, and now it's easy that common iliac vein combine and form IVC. Now from IVC we can directly enter into the gonadal vein on right side, and for left side first we will enter into the left renal vein and then into the gonadal vein. So this is the therapy, sclerotherapy and transvenous embolization of the varicocele by integrate and retrograde mechanism. Now let's discuss the open abdominal approach or the suprainguinal approach, or we can call it a retroperitoneal approach. So the retroperitoneal or suprainguinal approach or abdominal approach, we can perform it laparoscopic or through open mechanism, but again the whole mechanism that we are entering into the retroperitoneal space. This is also called Palomo approach. Why many of the surgeons is prefer this Palomo approach? The advantage is that good approach can be achieved if there is a previous inguinal scar or there is some surgical scar at the inguinal region. And the second advantage of this is that you can get the whole vascular pedicle, you can ligate it, and there are fewer veins at this level. So these are the advantage that many of the surgeons performing Palomo approach. Having good approach, if the patient having inguinal scar or inguinal surgery previously done. The second advantage that you can get the whole length of the vascular pedicle, and the third advantage that the artery is large size and you can identify and prevent it from ligation, and so there is a less risk of vascular the testicular artery ligation, and there are fewer veins at the level of at this level. So the disadvantage we will discuss that later on. And for this Paloma approach, the incision is actually given at the level of the internal inguinal ring, and as we have shown this in picture, and the various layers that to be split in this incision, including the splitting of the external and internal oblique muscle, and then exposure of the internal spermatic artery and vein retroperitoneally near the ureter. This approach has the advantage of isolating this internal spermatic vein approximately near the point of drainage into the left renal vein, so we can go at a very high level. So at this level only our two large veins are present, and in addition the testicular artery has not yet branched and is often distinctly separated from the internal spermatic vein, so that's why it's important. So after suprainguinal or retroperitoneal approach, let's discuss the open inguinal varicocelectomy, which is also called I1 Wish technique. What we are doing in this, we are actually giving a 5 centimeter incision as I have shown in this picture. A 5 centimeter incision is made over the inguinal canal, then we are opening the external oblique epineurosis, and then the encirclement and delivery of the spermatic cord. The cord is then dissected and all the internal spermatic veins are ligated. The advantage of this open inguinal varicocelectomy or I1 Wish technique that it is easier and quicker approach, especially in obese patient, and the easy identification of the cremasteric vein and the good mobilization of the cord is possible. But the disadvantage that we cannot perform this procedure in a patient having a history of previous inguinal surgery. Now let's discuss the subinguinal or inguinal microsurgical varicocelectomy, which is also called murmur or gold stain technique. The advantage of this microsurgical, which is a gold standard procedure for the varicocelectomy nowadays, as it provides the advantage of facilitating artery and lymphatic sparing, there is a high rate of success, there is a low risk of hydrocele, and the approach can be used if there is a previous inguinal surgery of the inguinal region. But the disadvantage of this microsurgical technique that it is very time consuming and that is require microscopic surgical scales. Now the incision around 2.5 to 3 centimeter incision is made over or just above the external inguinal ring, and the spermatic cord is isolated with or without opening the external oblique fascia. So after the mobilization and dissection of the cord, you can ligate all the visible vein, and then the delivery of the testes in this incision, like in microsurgical incision, if you want that there is no that there should be no recurrence of any hydrocele, better to deliver the testes, as around the much of the time the delivery of this testis gave you access to much of the external spermatic collaterals, and there is ligation of these collateral will prevent the 10% recurrence of the varicocele. So after the dissection of the cord and ligation of all the visible vein, so better to deliver the testis and ligate approximately around 10 of the veins around the testis, and this lead into a good result. Now it is also important how to identify the artery during this whole procedure. The artery can be identified by the visualization of the pulsation under this higher 225 in great magnification. The other mechanism is the application of the 1% favipiravir that causing the dilatation. The other, we can use Doppler ultrasound probe which can tell us about the artery, and the fourth mechanism elevation with partial occlusion followed by release, and that's leading into the visualization of the pulsation within the vessel suspected to be an artery. Now what is the post-op recommendation and the post-op instruction to the patient? The sexual intercourse should be start for 4 weeks, and the semen analysis will be repeated after 3 months, and then we will discuss the various complication of this various procedure. In case of inguinal, like I means the suprainguinal or the Palomo procedure or the retroperitoneal procedure, the recurrence is around 5 to 15%, and the occurrence of hydrocele is 3 to 30%. While in microsurgical technique, the recurrence is 1% and the formation of hydrocele is 0%.